session is 45 minutes in length, and if time permits, Dr. Shin will be happy to address a handful of attendee questions after her talk. Please note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Here at IDF, we offer a wide array of educational presentations, including those developed by healthcare and lifestyle management professionals who we have invited to present at this conference. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of IDF. And without further ado, I'm so proud to introduce our presenter, Dr. Jenny Shin. Dr. Shin is a physician scientist at Yale University, where she specializes in primary immunodeficiency disorders with a particular focus on Hyper IgM syndromes. Dr. Shin is a 2023 IDF research grantee, and we are thrilled to have her here today to share on these critical research efforts for the IgM community. Welcome, Dr. Shin.
Hi, everyone. Very nice to meet you all, and thank you for the very generous introduction. And I'm very happy and honored to be here and present my work. So today I want to share some of my research work that I'm doing, focusing on CD8 T cells and how looking at CD8 T cells might give us idea the prognosis and outcome of CD40 ligand deficiency. No conflict of interest. So I'm gonna start with a patient of mine. So he really inspired me and motivated me to do this research. So he was 6 months old, baby who came to the emergency room at Yale with not able to breathe well. So as soon as he came in, he was very ill. I mean, his oxygen saturation was very low, so intubated, and they were looking for the source of infection. And he had PJP, and he had CMV. And then the family history was very interesting that his grandfather, who was pretty young at that time, was diagnosed with Hyper IgM and started IVIG in his 20s. And also he told us that he was very, very ill when he was young, and he was kind of living in the bubble. And he also shared that his brother died at a very young age due to some kind of infection, and he thought it was most likely lung infection. So looking at the family history, you know, the grandfather, maternal grandfather, and the grandfather's brother, so likely the mom is the carrier and the boy has the disease, so it must be X-linked. And based on the cultures of the pathogens that we found, we had a high suspicion for CD40 ligand deficiency. So looking at the immunoglobulins, it was consistent. IgM was high, IgG was low, and then flow cytometry showed that the patient and the grandfather had no expression of CD40 ligand, whereas mom was a heterozygous, so had about 50%, and healthy control that we had as a control was full expression. And genetic studies show that patient had deletion at a very early position of the DNA that caused the frame shift, which means that the entire DNA got messed up and none of the CD40 ligand was able to be expressed. And then yesterday, Dr. Ramsey showed us a nice introduction of our X-linked CD40 ligand deficiency. So this is the same thing what he gone through yesterday, that CD40 ligand is expressed on T cells and CD40 is expressed in B cells. So when the T cell receptor gets activated, CD40 ligand gets expressed on the surface of T cells, binds to CD40, and then B cells gets activated, and all these IgM should switch over to IgA and IgG to protect us. But without having CD40 ligand, we can switch from IgM to IgG or IgA, and then there is a problem with both T cells and B cells. And I think the same article was discussed yesterday that there was a study by Dr. Morena and published in JACI in 2017 showing that the median survivor was 25 years, but I'm sure this is kind of outdated. Now we see, people surviving beyond age 40, 50, 60 sometimes. And we all know that the transplant is the only curative approach for CD40 ligand deficiency, but in this article, it didn't seem like there was a significant difference of survival with or without transplant. However, there is definitely improved quality of life in patients who underwent the transplant. But our patient did not have a match at that time, and also, not very compliant with all the treatment. So it was very difficult to decide whether to transplant him or not. But at the same time, when we are not transplanting him, we were very, didn't know how to monitor him closely and what will be the outcome. And another interesting finding from this 2017 paper is that liver disease is actually a significant predictor of overall survival. So this was a very important information for, I think, all of us. And, to me, okay, so monitoring liver is so important, but, it's not very easy. I mean, we can check LFT, but what else can we do? Ultrasound to see whether it gets bigger, but is there anything more we can, have to monitor these people's prognosis? And then, the more recent paper in JACI shows that there are improved outcome in transplant, and one of them was age less than 10, and our patient was right at age of 10, and we got so nervous, like, should we transplant him now, or should we wait? But what will be the outcome if we transplant or not transplant? So, I think, a lot of us go through this dilemma, whether transplant or not transplant, what will be better? So in the absence of transplant, the long-term therapy is required for immunoglobulin replacement, antiviral prophylaxis, and close monitoring of infection, liver disease, and malignancies, which is what we all do, but I was really hoping that there is better way to really monitor. So my questions were, is there a blood test, some kind of biomarker that I can use to monitor prognosis of these non-transplanted CD40 ligand deficient patients? And is there a blood test that can give us a prediction for liver disease and poor outcome in non-transplanted patients? So at that time, this was about, I think this is when I was a clinical fellow, and I was working in a Dr. Insoo Kang's lab who does a lot of CD8 T cells research. And he also looked at aging research, so he looked at CD8 T cells as a marker for aging. And this Nature paper is basically showing us that what happens to our CD8 T cells when we age. So, a lot of things happen, like are we gonna have less naive T cells, and, our thymus will get smaller, and, mitochondria will not work as well, and there will be some kind of genetic modification by epigenetic changes, and there is something called T cell senescence at the bottom. So this is basically meaning that your T cells are becoming non-functional. They are there, but they are not doing what they're supposed to do. And you can see that all the arrows are pointing at immunodeficiency. So when this happens to your T cells, you're gonna have more infection, more cancer, more autoimmunity, and more inflammation. So this kind of looks like my patient. He's only 5-year-old, but his immune system is probably just like someone who's 70 or 80 years old. And that's why he's more prone to get more infection and more of the concern for malignancy and more concern for liver disease. So I start looking at my patient's T cells. CD8 T cells specifically. And then also there was some supporting data from previous studies. Dr. Flaubert, who is at Yale right now, but he's also the first one who found CD40 ligand. So in his mouse model of CD40 ligand deficient mouse, he showed that in here, he looked at CD4 T cells were not able to proliferate or respond properly to the stimulants compared to the healthy mice. And also the IL-4 and interferon gamma, the cytokines were not secreted properly in CD40 ligand deficient mice. And subsequently, there were more studies. And this was a very interesting study for me because this report demonstrates that CD40 ligand co-stimulation is critical role for rescuing exhausted CD8 T cells. So it's basically saying that you need CD40 ligand interaction to rescue all these CD8 T cells that are not doing what it's supposed to do, those who have poor functions. And then IL-21 signaling is also important, signaling for rescuing CD8 T cells, and that was suppressed in CD40 ligand deficient patients. Here was a mouse study as well. So there was really no human study looking at CD40 ligand deficiency, how it's affecting CD8 T cells. So my first study was looking at CD8 T cell senescence and CD40 ligand deficient patients. So I studied with my patient at Yale, but generous people out there, from CHOP, Nationwide, and NIH, they shared their patients' cells with me, so I was able to recruit them, and I looked at their T cells. And I divide them based on the adherence to their treatment. So immunoglobulin replacement and prophylaxis, and also their childhood recurrent infection history. So the ones in the red are non-adherent patients, and the ones in blue boxes are adherent patients. So here, it's a bit busy slide, but I will explain that. Do we have a pointer? No? Oh, no, okay, that's fine. So on the D figure, if you see that, that's a PCA plot, which means that I put all the variables, immune variables, and all the patients into the system, and it automatically grouped them based on the features, the similar features. So I had adherent patients, non-adherent patients, and older healthy control, pediatric healthy control, and young healthy control. And I stained all their cells with different T cell markers, CD8 T cell markers, which will characterize them based, whether they are more senescent or not senescent. And as you can see there, the darker green is a non-adherent patients, and they grouped together with the older healthy controls, which is the brighter green. And then on the other side of the bar that I have it there, the adherent patients who are in red grouped together with the pediatric healthy control and young healthy control who are in blue and pink. So this basically showed me that, okay, the patients who are adherent to all the treatments were able to have very nice young CD8 T cells. That's like the young healthy controls. However, the patients who are not adherent, even though they were very young, their CD8 T cells looked more like older people, meaning their T cells were more having the senescence phenotype. And then the other figure is a heat map showing unbiased hierarchical clustering of all the markers at the bottom are the T cell markers. And then I just put together all the healthy control with our little boy. And our little boy was grouped along with the older people instead of his own peers, which showing that his T cells looked more like older people going through lots of the senescence. So maybe the first maybe I answer partially about my first question. Is there any blood test we can monitor prognosis of these non-transplanted patients? Maybe CD8 T cell senescence characteristic is associated with recurrent infection and poor compliance and with supportive care, including immunoglobulin and antibiotic prophylaxis. So maybe not being, likely not being adherent to the treatment will give poor prognosis, and CD8 T cell senescence markers might serve as a biomarker. Then the next question, is there a blood test which may predict liver disease and poor outcome of these non-transplanted patients? So this is bulk RNA-seq, which means that, I sorted CD8 T cells of the patients and the healthy control, and I stimulated the cells with and without the TCR triggering, which means the anti-CD3, CD28, which stimulates the T cells. And then I looked at the difference between gene transcript of healthy controls and patients with or without stimulation. And the heat map on the my right side is showing that there is a pretty, big difference between healthy controls and patients. But we noticed that there were more difference in gene, gene transcript when the cells were not stimulated. So if you see HUN, which is a healthy unstimulated, and CD40 ligand UM, which is CD40 ligand cells unstimulated, it kind of reverse, right? The green is less expression, and red is high expression, and the colors kind of reverse in healthy and CD40 ligand. So it kind of gave me an idea that okay, there has to be a lot of gene transcript difference between healthy and our patients' CD8 T cells. And then we only look at the genes that are related to aging. And then the first two were very highly expressed in the patients were the genes that are related to promoting cellular senescence. So maybe our CD40 ligand deficient patient not having CD40 ligand will increase the expression of the genes that are promoting CD8 T cell senescence. Then I looked at different, this is the way we categorize the genes into different functions. So the biofunction means it's more of their biological functions. So if you look at that graph, the red means that it's more highly expressed in the patient. So the patients expressed more of the genes related to necrosis and cell death and apoptosis and inflammation. So unfortunately, not the things that can really promote more infection and cancer seems to be highly elevated in these patients. And then the other graph is showing more of by the organs. So it shows the kidney, heart, and liver, and some other genes. I think those were actually the major ones that came up. So kidney, heart, and liver. And then liver seems to be very highly expressed in the patients, the genes that are associated with inflammation of liver, liver damage, and cell death of liver in CD8 T cells. So CD8 T cells expressing high levels of these genes may be associated with causing liver disease in these patients. So this is, and then, I checked the T cell function in patients compared to healthy control. So I got the PBMC, the cells of the patients and healthy control, and looked at CD25, which is the T cell activation marker on CD8 T cells, which was decreased in patients. And I looked at the production of cytokines, the TNF-alpha and interferon gamma, the main pro-inflammatory cytokines fighting infection, so were also severely decreased in the patients compared to healthy control. So it summarize that, the CD8 T cell function is decreased. CD8 T cells are showing the features that are associated with inflammation and necrosis and cell death, and also possibly, liver damage. So summary of the study that I'm doing, is having delayed diagnosis of CD40 ligand deficiency and delayed initiation and poor compliance to the treatment can cause premature onset of CD8 T cell senescence, and having this premature onset of CD8 T cell senescence may lead to poor prognosis of CD40 ligand deficiency by further increasing the risk of infection, liver disease, and malignancy. But we still don't know yet because I only have my preliminary data. But just having absence of this intrinsic CD40 ligand mediated signaling may also put more stress on the CD8 T cells and have them to go through the premature onset of CD8 T cell senescence. And another part that I also want to explore is these epigenetic changes, because our DNA continuously gets stimulated by different medications that patients are on, and the environmental factors, everything just make everything get changed. So ATAC sequencing or global DNA methylation is looking at the epigenetic changes of the DNA itself that might be also contributing the premature onset of CD8 T cell senescence. So if we can figure out all the factors that might be causing CD8 T cell senescence, and if CD8 T cell senescence is really what's contributing to the prognosis, poor prognosis of the CD40 ligand and risk of more infection, liver disease, and malignancy, maybe there is a way that we can use CD8 T cells to monitor the prognosis of these patients. And also, maybe there will be eventually, develop a therapy that targets CD8 T cells that we can rescue these, senescence T cells to work properly, just like healthy controls. So I want to, introduce our allergy immunology group at Yale. We all work together, and especially when it comes to immunodeficiency patients, we all share our ideas and we try to really help our patients. And I work in Dr. Kang's lab. He's my primary mentor, and these are the people who help me with the projects. And without the collaboration from other centers, none of the work is possible. So I really appreciate everyone listed here. And I want to thank IDF for funding this study, and also Hyper IgM Foundation, who also funded my study, and Yale Center of Clinical Investigation and NINID for the support. And most of all, I do want to thank the patients and families. Really the patients motivate me to work, and my patient, gave me the idea, how am I gonna, monitor your prognosis? So that's when everything got started. So, without the patients and families, and without the contributions of the, the blood samples, we cannot do any of the work. So I really appreciate, and yeah, I welcome any questions. Thank you.
Sorry, real quick, we are going to get to Q&A. I just want to next welcome Akiva Zablocki from the Hyper IgM Foundation. If you want to come up and say a few words.
I'll just give it a try. We're promoting our podcast now. We haven't tested out yet. Hyper IgM about the patient experience. We've had 2 episodes so far, and it's very insightful. And if any of your kids want to be on the podcast, let me know as well, and we'll make it happen. Thank you, and thank you, Dr. Shin, for everything.
All right, thank you, Akiva. And we are going to transition to a brief Q&A in just a moment, so don't worry, you will have a chance to ask your questions. Really quick, though, as we transition, I just want to share a couple of IDF resources. So if you have any questions that were not addressed in this awesome session, we invite you to reach out to our Ask IDF resource, and a member of our team will be able to help answer your question or direct you to appropriate resources. And then I also want to make sure everyone knows about our IDF Get Connected groups. They are virtual support groups for individuals diagnosed with PI and their family members, where they'll have the opportunity to connect with one another, share experiences, and receive support in their local communities. And then finally, my last little reminder, we hope that you will take just a moment to go into your conference app and let us know through the session survey what you thought of this session and what we can do better in the future. So we do have time for a quick Q&A. I'm going to bring the mic around for those who want to ask questions. We just ask that your questions are related to the session and the topic at hand. So I will come around and bring you the mic in just a moment.
I think the first question was what will be my next step, right? So first, this was preliminary data. I did, RNA-seq only on 2 healthy and 2 patients. So I do want to expand the pool to make sure, it's not just happening to, 1 or 2 patients. And another thing is I want to make sure, that whether there is a difference between people who are not expressing any CD40 ligand or people who are expressing CD40 ligand but not having able to bind to CD40. So I do want to see the difference between those 2 cases. And also, if what I'm showing you today, it's consistent with, more patient samples, then the next step will be verifying those genes, because RNA-seq is kind of more of the screening. So after we do this, we usually do more specific testing like a PCR or flow cytometry or Western blot to make sure these genes are really expressed lower or higher in the patients, and then also looking at their protein levels to make sure the protein itself is also differentially expressed. And then if it's really related to, the genes that are related to liver disease or liver damage is highly expressed in the patients, what I want to do is that, we can get this liver tumor, in vitro, and then I want to see, whether the healthy control CD8 T cells can kill those liver tumor cells better than CD40 ligand deficient patients' CD8 T cells. So if that's true, then it really means that CD8 T cell alteration is causing, maybe contributing to liver damage. So that might give us a potential for having a therapeutic implication.
Okay, thank you, Dr. Shin. Does anyone else have any questions before we close out this session?
Hypothetically, if you're able to show the test for the T cell aging that is a indicator, would other centers be able to replicate it easily, or have you developed a method that is not going to be?
No, everything I did is very basic immunology techniques that, anyone in immunology research will be easily, replicated.
All right, here we go, Dr. Fuelhan.
What? Oh, no, not a clinical labs. It's not a clinical diagnostic, test. It's a more research-based. Yeah. But then, I don't know. Maybe Dr. Rashini Abraham does T-cell senescence testing?
She might, or
Yeah.
she certainly would probably be able to do that. Very nice work.
Thank
nice
you.
to see some functional data, and maybe it'll be very exciting if there's differences between patients, or if patients who are treated versus not following their treatment, and maybe help us or help families try to decide what path to take in terms of treatment. So nice, very nice work. Thank you.
Thank you.
All right, well, thank you so much, everyone. I think that's going to close out this session if no one else has any further questions. We do want to thank you so much, Dr. Shin, for this awesome talk today and for this wonderful work that you're doing for the Hyper IgM community. I want to thank Akiva Sablaki from the Hyper IgM Foundation for being a part of the conference today. And thank you all for joining us here in Chicago. This is our last session of the day, so I know we have lunch out in the hallway if you all want to go enjoy, and we wish you safe travels as you all head home from the conference. And it was really great getting to see everyone in person. We really appreciate you making the trip to Chicago and being a part of this event. So thank you so much.